Hello, everyone. Welcome to our panel on breakthroughs and approaches to chronic pain. As Ben said, my name is Magali. I am the Chief of Operations and a Program Advisor to PPA, which is the Psychedelics and Pain Association. I'll just say a note about PPA. We're a very grateful grantee of the Cohen Foundation. And we are the central organizing body for a lot of the research, the education, and the advocacy that's happening in the realm specifically of psychedelics for the use towards chronic pain and physical conditions. I'll also briefly say that this conference means a lot to me. I'm also a licensed healthcare practitioner, and a large portion of my patient population has been the chronic Lyme disease community in the last 10 years. And it's through the stories of my chronic Lyme clients that I actually learned about the potential of psychedelics for uses outside of mental health and psychiatry. It was through those Lyme clients using psychedelics to treat their pain and their physical conditions that I became really interested professionally in that potential. So being here at this conference and seeing those worlds come together is really amazing for me as a practitioner, and just want to give a little shout out to Johns Hopkins too for the Lyme and psychedelic study that's happening there. I think we're all really excited to see that come to fruition and look at that data. So without further ado, our panel. I will start with brief introductions for each of them, and then they'll go through their presentation. So starting with Dr. Laura Tabikoff. Dr. Tabikoff is the Director of Research and Precision Recovery at the Icahn School of Medicine at Mount Sinai, where many of us were yesterday for the beginning of this conference. And she and her team are developing really novel, non-invasive, non-pharmacological interventions for the treatment of complex chronic pain. So she'll share some what's happening at their lab. Yeah. Next, we have the immense privilege of hearing from Joe McKay, who's a colleague of mine. He's a board member at Clusterbusters, which is a psychedelic organization supporting people. It's a cluster headache organization that helps people understand how psychedelics might be helpful in the use in the treatment of their pain. He's a retired FDNY firefighter, and it's a truly compelling story. So, last we'll hear from Dr. Adam Halberstadt, who comes to us from UC San Diego's Center for Psychedelic Research, and he's also a professor of psychiatry there. And we will be learning about the trial that they're running on phantom limb pain and psilocybin. So, awesome lineup. So we'll start with Dr. Tabikoff.
Thank you, Magali, and thank you so much for having me. This is such an inspiring event. I think having so many minds coming from different places is how we're going to make a difference. I don't see my slides up.
Do you not have your clicker?
No.
No, there should be a clicker.
We're missing her clicker.
I can get started. I don't really need my slides, but they just give a nice visual. I usually like to start my talks talking about the importance of targeting the brain when treating chronic pain. So why is that important? Yes, there you go. Okay, that's me. So why do I like to talk about the importance of the brain when targeting pain? Because every pain that has been persisting for longer than 3 months, so any chronic pain, comes with substantial reorganization of parts of the brain and those neural pathways. And that's something we call central sensitization. Now, as an effect of this central sensitization, what happens is a disruption of how sensory input is interpreted. So oftentimes, input that is just a normal light touch, if a person has persistent pain and we have those alterations in the brain, this is interpreted as painful. So I like to bring up this quote from Moseley. Dr. Moseley is a pioneer in pain neuroscience in Australia, and he's brilliant. If you haven't seen his work, I highly recommend. But the concept is the longer you have pain, the better your nervous system gets at producing these danger messages to the brain, even when there is no danger anymore. So it's really important to treat pain symptoms in order to stop this debilitating cycle of chronic pain leading to more pain and so on. Now, the challenge is that pain treatments, as we know, are often quite limited and oftentimes dangerous. So our mission at Mount Sinai is to disrupt how chronic pain is understood and treated by the medical community, by patients, by caregivers. Everyone needs to update their understanding of chronic pain so that we can create a new generation of non-pharmacological and non-interventional pain therapies that can be accessible and effective. So how do we do that? That sounds easy to say, but we are currently developing and working with alternative or complementary brain-focused approaches to harness brain plasticity. So the idea here is to focus on neuromodulation, so modulating brain activity so that we can decrease pain symptoms and find relief. So here in this image, we can see a few of the technologies that we work with. So we work with transcranial magnetic stimulation, which is a popular form of non-invasive brain stimulation, often used for depression treatment. We also have gamified therapy. We also have mirror box therapy and virtual reality. So I'm going to talk a bit more about a very exciting paper that we just published on Pain Reports. So in this paper, we included 22 individuals with chronic neuropathic pain after spinal cord injury. We randomized them into 3 different groups. So some people received a virtual environment where they were placed in a very beautiful landscape. Here we have Central Park in the image. The second group was randomized into a somatic group. So that group really mimics what mirror box therapy does. So the idea is that individuals were placed in an environment where they saw in a first person's perspective limbs getting very sensory eliciting activities such as finger painting or feet playing in the sand. And the third group was a control group. Where people randomized they just got a black screen with nature sounds. So everyone did 12 sessions of virtual therapy 3 times a week for 4 weeks. Fun fact, there was a pandemic in the middle. So we had to pivot, and beforehand we had people coming to our clinic to do the sessions, and after that we just arranged a set of virtual headsets and we sent it to people's homes, and we set up a YouTube link, and people were able to complete the clinical trial from home. So that was a good example of how it can be scalable too. So getting into the results, we initially hypothesized that the somatic group would be the only group that would had good outcomes, but actually the scenic VR was associated with significant short-term reductions in neuropathic pain. And very exciting finding was that enjoyment of the environment and the feeling of being present in the environment were associated with greater reductions in pain, meaning the more people enjoyed and the more present they felt in the environment, the better their pain outcomes. So that was just a pilot study, but it really is informing the future step, which is developing a new generation of high immersion, personalized virtual environments that can be personalized according to physical features. So you can see here on the left the environments that we used then, which is quite limited, and we just built a few in-house with a little virtual reality camera. So we didn't have the good array of physical features, so people felt like they couldn't embody limbs that didn't look like themselves. So that's the new step, like developing a next generation and collaborating with industry, with the gaming industry, and finding the right partners to really advance that research. But there's a lot of hope there. Thank you. And that's just some part of my team.
Thank you, Dr. Dabakov. I think many of the psychedelic people in the room can imagine some collaborations happening between VR, immersive technologies, and psychedelics. So I think it was Christiana and Michael Pollan who said earlier that patient stories are really what drive things at conferences like this when we're all together and we have many experts in the room. So I'll pass it to Joe McKay for his patient story.
Hi, everybody. I hope today I can give you a picture of how psilocybin changed my life. I come from a family. I come from a family of firefighters. My brother, I got uncles and cousins on the job. It was me back in the 70s. My uncle was holding me there in front of the fire engine, and we kind of flipped the script decades later. But yeah, for me, it was a dream come true to become a fireman. Click. Next. So it was a beautiful morning on September 11th, not unlike today, not a cloud in the sky. I was off duty helping to run an FDNY fundraiser, and when we got the news, and we gathered around the TV to watch the news coverage like everyone else. And then we saw the second plane hit, and at that point we knew it was no accident. We commandeered a city bus, and we actually did that, filled it with equipment, and we responded to the World Trade Center. So when we arrived here at Ground Zero, there was still a threat of other planes in the air. There was concerns of secondary explosive devices spread throughout New York City. But we got to work searching for survivors and putting out fires. And I remember the building that we're in now, as I was one of the firemen here, searching this building on that day. Looking back, it was like hell on earth being down here. It felt like I was living in an apocalyptic movie, but it was really happening. 343 firefighters were killed. I knew 26 of them, and 4 guys were from my engine company. Yeah, in the months following, after 9/11, we were working on the pile, breathing in that toxic air. And, when we were searching for the missing, hoping to bring some form of closure to many people that lost family members. If we weren't here at Ground Zero, we were helping the families of those we lost, or we were going to funerals or memorials. And, sometimes there were 8 in a day, and we just couldn't get to all of them. So needless to say, we weren't in a good place. And I thought, I had hit rock bottom at that point and said, nah, things can't get any worse. And then I got my first attack. I woke up 1 in the morning feeling like someone had just stabbed me in the eye with a burning hot ice pick. I'd never experienced this much pain in my life before. I thought I was having an aneurysm, and I figured I'm checking out, I'm gonna die. I ended up in the emergency room, and the attack lasted for about 90 minutes. And I was sent home a couple hours later with no answers. The attacks continued, mostly at night. And after a while, a few more nights later, I just gave up on the emergency room because there was no painkiller or anything they were doing at the hospital that made a difference. And I would just bang my head against the wall to distract myself from the pain. And this is common among cluster headache patients. I scheduled an appointment with a neurologist, and a few weeks later, I was diagnosed with cluster headache, otherwise known as the suicide headache. It's one of, if not the most painful conditions known to medicine. 70% of cluster headache patients report having suicidal ideation. And yet, here I am. I think I consider myself lucky in a way that I got diagnosed pretty quickly. Because the average time for someone to get a proper diagnosis of cluster headache is 5 years. So if you can imagine 5 years of dealing with that kind of pain with no help, and no answers. A few weeks after my diagnosis, the attack stopped and I went into remission. But next year, around the same time, the attacks came back with a vengeance. And once again, the attacks came mostly at night, depriving me of much needed sleep. And this time, the cycle of attacks was lasting much longer than before. And over the years, doctors have prescribed many prescription medications for me that did little to nothing for the pain. And, it was costing me thousands of dollars a month out of pocket for my medical care. In 2010, things got a lot worse for me. The methods I was using to cope and abort the attacks were no longer working. I was on medical leave for months from the New York City Fire Department. My FDNY doctor had been telling me that I probably wasn't fit for duty and that I should retire. Being desperate to escape from the pain, I did, and now I had to give up the best job in the world. I mean that. Being an FDNY firefighter was the best job in the world. The next few years were tough, and I lost my career and my identity a bit. I got hooked on prescription painkillers, and sorry. Yeah, I got hooked on prescription painkillers, and as if I wasn't depressed enough, I fell into a deeper depression. In 2017, my cycle of attacks was going on for 7 months straight. During the peak of the cycle, I was getting 8 attacks a day. I was unable to sleep for more than an hour without getting an attack for 3 weeks straight. At that point, I was a zombie. I was unable to think clearly. And I started thinking about how I was going to kill myself. Yeah. Click. Being desperate, I searched the internet and I found a group called Cluster Busters. They had a study that said that they would, at Harvard, that found that psychedelics could be helpful with cluster headache. So I called a friend of a friend who knew a guy that used to go, everybody's got a guy who used to go to Grateful Dead concerts. And yeah, I ended up with a small dose of psilocybin mushrooms. I got the nerve up, I ate them, and let's just say I had an interesting afternoon in my backyard. But the next day, there were no headaches. The headaches were gone. I was in remission, and psilocybin gave me my life back. Over the next few years, I would take occasional doses to keep the attacks away. And during one of those experiences, I had this 10,000-foot view of my life, and I realized how I had changed since 9/11, and that I was living with PTSD. I sought out help from an underground therapist because I didn't qualify for anything above ground because I have someone in my family that has a mental illness. I spent some time with that therapist, and during a breakthrough session, I relived 9/11 and a lot of the horrors that I witnessed that day. And these insights, allowed me to make changes in my life. Today, I no longer drink alcohol. I have not taken a painkiller since the experience, and I can honestly say that psilocybin healed me both physically and mentally, and it's given me my life back. And it's not just me. Yale has done randomized controlled trials with psilocybin for cluster headache, and the findings prove what we already knew. These medicines work. Yale has also done RCTs for psilocybin, with psilocybin for migraine as well, a headache disorder that affects 1 billion people worldwide. These results were also positive. So we at Cluster Busters gathered data from headache patients around the world on their use of various medications and other substances, including psychedelics, and how they work for them treating their cluster headaches. And the results are clear. Psychedelics work far better than any FDA-approved substance. And I got to tell you, the side effects are a whole lot worse from the prescription medications than they were from many challenging psychedelic experience that you could experience. So given my experience and the experience of many that we know with chronic headache conditions, I'm not surprised that we're all sitting here today at this conference talking about how psychedelic medicines could be helpful for a wide range of pain conditions as well, and even other physical conditions like long COVID and Lyme. Look, all I can tell you is these things work. I think I'm preaching to the choir here with you guys, but it's up to all of us, and I mean that, all of us, to come to a better understanding of how these things work and who they might work for, and then we need to share this knowledge with the world and expand legal access. And I say this all the time, no one should go to jail for trying to heal, period. That's it. Thank you.
Thank you, Joe.
Thank you.
I feel so lucky I get to work with Joe. And hearing that story, there's always something else for me to take from that. So thank you. And this is why we need patient stories at conferences like this. We need to hear from the people who these technologies could benefit, and we need to hear from people who have not found benefit from existing therapies. We need to be reminded of this. Okay, so Dr. Halberstadt, if you could,
Sure.
I'll pass that down to you. Tell us about what's going on with your very exciting study.
Sure, yeah. Thank you so much for inviting me to talk about our research with psychedelics and chronic pain. And we just heard a really compelling account of how psychedelics can relieve pain. And I wanted to bring your attention to one effect that's actually really novel, which is that in cluster headaches, psychedelics aren't just relieving pain acutely, they're actually interrupting future attacks. And that's actually a really novel effect. So if you think about morphine, for example, when people take it, it may relieve pain, but as soon as it's metabolized, it wears off and you have to take it again and again and again. And that's part of the problem with drugs like that. They don't last very long and you have to keep taking them. And then you can get tolerance and addiction. But psychedelics seem to work differently. And if they actually work that way, it's really, really novel. And there's hints of that. Oh, there we go. So there's hints of that in the literature too. So way back in the 1960s, Eric Kass was a physician, and he gave cancer patients that had chronic pain LSD. Now, LSD typically acts for about 8 to 12 hours, but they were seeing pain reductions for 2 to 3 days. I think one patient had reduced pain for 13 days. That's unheard of with existing analgesics. And it suggests that psychedelics are really having a different kind of effect, almost like they're kind of interrupting pain or resetting pain. And that would be a really novel action. And the same thing seems to happen with cluster headaches too, phantom limb pain. So phantom limb pain is a really horrible disorder. It's really common in amputees to have phantom sensations in the amputated limb. And oftentimes the phantom sensations are really painful. And because there's no pain sensations to block it, there's no peripheral basis for the pain, existing analgesics really do nothing for phantom pain. And a really good example of this is the case of Albert Lin. You can see him there on the screen. He's a UCSD investigator, but he also has a National Geographic TV show. So he travels around the world visiting archaeological sites, ruins, and things like that. So he's really active, but he had an ATV accident and it crushed his foot. And he had really bad phantom pain, and he could just not relieve it. No medication worked. Finally, his doctor, out of desperation, suggested he try magic mushrooms because, hey, maybe it would do something. But after 2 doses, the pain went away and never came back. And they published a case report about it, and there were actually some case reports from the 1960s where people had taken LSD and it had cured phantom pain. And I was really surprised when I read these case reports because that's a really novel effect of a drug to actually relieve pain and persistently do that too. And I really wanted to run a clinical trial testing a psychedelic for chronic pain, and this seemed like the ideal indication because there's absolutely nothing currently that works to relieve phantom pain. So we've been running a series of double-blind, placebo-controlled trials testing psilocybin in amputees with phantom pain, using niacin as the placebo, and niacin induces some physical effects, but it doesn't induce a trip. And these studies have been funded by the Cohen Foundation. We just finished the first study recently, and that study was primarily looking at safety, because while it's pretty routine to give subjects psilocybin in trials, that's not the case for the amputees. They tend to be a traumatized population, but amputation can also affect blood pressure. And the FDA was really afraid that maybe psilocybin would produce excessively high blood pressure in the amputees. So we primarily looked at safety, but we also got measures of efficacy and potential brain mechanisms with fMRI. So we enrolled in the first trial 9 subjects. 5 received psilocybin, 4 received niacin. we found it to be really safe. So there was almost no physiological effects, no increases in blood pressure, no effects on heart rate really, no psychological issues, so no trauma was dredged up. And really the only side effects we saw were that 3 subjects had a post-dosing headache and 1 subject had nausea and vomiting. But those are pretty well-known effects of psilocybin, and they're not concerning at all. But in terms of pain, here's self-reported ratings of phantom pain intensity on a scale of 0 to 10, where 0 is no pain, 10 is the worst pain imaginable. And you can see that these subjects have a pretty severe amount of pain, 8 out of 10 in the niacin group, 6 out of 10 in the psilocybin group. And niacin did nothing to the pain. It was pretty stable throughout the trial and the follow-up. But you can see that psilocybin, 2 weeks after dosing, produced a significant drop in pain. And even by the 4-week point, although it wasn't significant, there was still less pain. And for the number of subjects we had, this is a pretty remarkable result, I would say, and definitely requires, justifies following up on that. And we're doing that now with a larger trial. So what about the brain mechanisms? Well, so we ran fMRI at baseline and then 1 day after psilocybin. And we suspected that maybe the default mode network would be involved in the effects of psilocybin. That's a set of brain regions involved in self-referential processing. They're involved in pain, and they're also affected by psilocybin and LSD. So we thought maybe they'd be involved in the pain relief. And that's exactly what we saw. So looking at functional connectivity, 1 day after psilocybin administration, there were changes in activity in the default mode network, and that was correlated with reductions in pain 1 month later. So just to summarize, we found that psilocybin reduces pain in phantom limb patients. We found that the effects are persistent, so they happen for a really long time after administration, for weeks. And we potentially identified a brain mechanism too that may be driving that. So I think this is really exciting, definitely deserves further follow-up, but it really seems like there's a potential there to make a huge difference in the lives of these patients. So we're really excited about going forward. And I just wanted to thank all of our collaborators. It takes a huge number of people to make this work. And I want to thank the Cohen Foundation too for supporting the trial. Thank you very much.
Thank you, Dr. Halberstadt. So we do have a few minutes for Q&A from the audience. If anyone would like to ask a question of our esteemed panel. If not, I have some questions. Well, like I said earlier, was there a question? Okay.
As a Black woman with long COVID, one of the things I've run into is drugs or treatments that have stigma to them are not in our best interest to participate in until the stigma is gone, because it just makes our life harder when medical people see that we are taking these things. So my question would be, what strategies do you foresee would help in the Broadway of getting people of color access to these treatments without it becoming detrimental for them?
That's an excellent question. It makes me think about Cluster Busters and the citizen science that happens there, and the way that patient organizations break this stigma through community. So Joe, if you want to speak to that, and I'd love to hear what our docs have to say on that too.
I think people of color with stories, like myself, someone that's benefited from it, they need to be put out in front. They need to be up here on the stage sitting next to me. There's no better way to break the stigma when you have a person of color up here that you could relate to, and everybody sees it. So that would be the answer right there. Just have people that have benefited from psychedelic use, men, women, people from all different colors. We need everyone to help us get this this done. It's not just a bunch of white dudes or PhDs. We need regular people, everyday people. Thank you for the question.
Did either of you want to add on to that at all? In terms of breaking stigma, I mean, you can speak to that too. And, you know, working with these compounds, there is, of course, a big stigma. And as Michael Pollan mentioned earlier, you know, there are a lot of people who have not yet made their decision on how they feel about psychedelics. And so how do you see your work contributing to that?
I think we just have to really expose people to these substances, and education, I think, is paramount. Having more data, too, is really important, because once these substances are approved, I think that'll go a long way. There'll be many more people taking them, and the stigma will gradually fall away. But also developing new compounds that don't have the stigma, too. I mean, one of the reasons why LSD was sort of deprioritized and psilocybin has kind of come to the forefront is because of the stigma. And so I think that maybe developing other compounds, too, will help with that. But also just moving forward as there's more evidence of efficacy, as these drugs become FDA approved, I think some of the stigma will also just kind of fall by the wayside too. So I think it's just a matter of really time and generating more data.
Thank you. Were there other questions from the audience? No? So, oh.
Hi, so I'm curious thinking about the phantom limb pain. My background being in neuroscience, I'm curious if, you know, when the limb gets cut off, effectively some form of referred pain, and that the psychedelic experience might alter how much of the parietal lobe is assigned to that phantom limb that is no longer there, and can help reassign that area of the brain to other areas of the body, so that effectively the patient's just no longer paying attention to it and their brain isn't looking for signals that are no longer there.
Yeah, so one of the theories about phantom pain and why it happens is that there ends up being a discrepancy between visual input and somatosensory input, so there's never remapping. And so, you know, you see that there's no limb there, but the somatosensory cortex still thinks it's there, and the brain kind of freaks out and is trying to basically get the patient's attention by producing a lot of pain. And so maybe psychedelics are facilitating remapping, and that reduces the pain by basically removing that discrepancy. So that's one possible explanation. It would be really really interesting to actually see what happens with remapping after we give psilocybin. So I definitely agree that's an interesting point.
I'm a practicing physician, and all this is very new to me. I have heard about the use of these drugs in my patient population, HIV, and I always assumed that this was sort of, you know, a way to help escape pain or some reality. But in fact, it sounds like something much more fundamental is going on. And in fact, there's something, it could be curative, as it was in your case with the cluster headaches. And so I'm wondering if it's a branding issue. I mean, why are we referring to it as the psychedelics? Because that has all these implications of hallucinations and everything else, and LSD and so forth. And maybe that, because the person who talked about stigma, I mean, I think taking psychedelics is going to be highly stigmatizing. And so if we can find out the mechanism for how people are being cured, and perhaps come up with a different way to actually package this approach, that might help.
Well, I will say that the Cohen Foundation, because we're all here because of them, is doing a lot of the funding that allows that work to happen. We are seeing a lot of research coming out that's looking at defining what are the mechanisms of action for these medicines, on these really deep levels. And we have some of those researchers here in the audience today that are defining that in a way that allopathic medicine and more, data-driven science folks will understand, and it will round out our collective understanding of how to use these in a better way, in a more efficacious way, what applications they can be, moved towards. And I think we're all excited to see this work, these physical conditions being brought into the discussion here, pain and physical conditions of all kinds. So there is a lot of existing and exciting new research that's coming out that will hopefully fill those gaps and broaden our understanding. So, which will, of course, decrease the stigma is our hope, for sure. And I don't know if you want to add anything to that. We're right at 0. So, yeah. Thank you all.
Thank you.